Hi, I'm Dr. Charlie Procter with Beltline Health here in Atlanta, Georgia, and today's topic is what are some things that can occur down the road after a sleeve gastrectomy or a gastric bypass that would require an upper endoscopy or more diagnostics to figure it out. With any operation, there's always a possibility of having something occur right around the time of the operation, such as a leak, bleeding, blood clots, those types of things. But unique to operations when we on the stomach, especially on an operation where we're making the stomach much smaller, we can run into issues down the road that you need to know about and that kind of need to know how to self-diagnose so we can help steer your care. So let's talk about first sleeve gastrectomies. Sleeve gastrectomy is a great operation where we take a normal stomach, we slide a calibration tube down into the stomach. We use that calibration tube to staple along to gauge how much of the stomach that we leave behind. Now, once that tube is removed, what you have is a long, narrow tube of a stomach that's the shape of that tube. And in most cases, that's going to be just fine. But think about this. Most stomachs are sort of shaped like a big U, sort of like this, or a C or a J. Everybody's got a little bit different stomach. And that's fine. If you have a big wide stomach and it makes a turn like that, not a problem. What if I now have a very narrow stomach that wants to make the same turn and it creates a kink? If you think in your mind holding a garden hose and bending it like that, it's going to create a kink down there where it impedes things flowing through. This is something that can develop down the road after a sleeve gastrectomy, and generally patients will present and say, I was okay for a while, but it's gotten harder and harder to get things down, and now I'm just refluxing all the time. I'm starting to throw up. I can't eat very quickly at all. I have to wait, and what this tells us is there's some kind of something going on to impede the flow of food. A couple of ways we can diagnose what's going on. Number one is radiographically. We can have the patient drink some contrast as we watch it go through the fluoroscope. Oftentimes what we'll see is that contrast come down into the top of the stomach, and if it doesn't go through right away, the top of the stomach will dilate up as that fluid is sitting there, and we'll see it kind of trickle through. That's one way to get an idea if you're having what we call a stricture down in the middle of the stomach. The other way is to diagnose it directly with an upper endoscopy. That's where you come to the hospital or the endoscopy suite, you go to sleep, and we slide a scope down, a camera down inside the esophagus. We go down into your stomach, into the sleeve gastrectomy, and we can see, is it a good caliber all the way through, or is there a place where it's kinked? And if we find a place where it's kinked or it's too narrow, sometimes we can remedy that by sliding a balloon through the scope and stretching out that area a little bit with the balloon so that things flow through more readily, and sometimes that will take care of it. In instances where that doesn't take care of it, that narrowing sticks around no matter what, and we just can't get it open enough for the patient to eat very well, oftentimes that's a reason that we need to convert that operation to a gastric bypass, where what we would do is go back to the operating room, divide the stomach above that narrowing area and use that as the gastric pouch, and then bring the small bowel up to that. That 100% of the time will take care of the problem. Now, what can happen with a gastric bypass? Well, a gastric bypass is an anatomy where we create a small gastric pouch, usually about the size of 2 fingers, and then we bring the small bowel up and we sew it directly to that gastric pouch. Now, when that happens, where the small bowel is sewn to the pouch, we do that with sutures or with staples, that has to heal up. And generally it does without a problem every time. But some people are what we call super healers. And what we see happening is over time, as that's healing up, that opening will become more and more and more narrow. And generally you know exactly what's going on because a patient will call me 6 to 8 weeks after their surgery and say, Dr. Procter, everything was going great. I was getting all my fluids in, I was getting my food in, but all of a sudden now every time I try to eat something solid, it feels like it just gets stuck and I end up throwing it up. And I had to just go back to liquids, and now all of a sudden I can't even get my liquids down. Sometimes I even throw those up. What that tells me is that over time that opening has gotten more narrow. So that's definitely a reason to probably even skip the radiographic study, go straight to the endoscopy suite. We diagnose it by looking and seeing that that hole is too small for me to even pass the scope through. We just slide a little balloon in there, we'll stretch it out a little bit, patient goes home, and that generally takes care of the problem. So with both operations, you can get what are called strictures or narrowings in the tube, make it more difficult to eat. Actually much easier to take care of after a gastric bypass than a sleeve gastrectomy, believe it or not. So These are the things that if these are going on for you, then you need to contact your doctor about it. You also need to know about these if you're thinking about having one of these surgeries, so if this happens to you, you know right what to call your doctor about. This has been post-operative issues that can occur with sleeve gastrectomy and gastric bypass. I'm Dr. Charlie Procter with Beltline Health in Atlanta, Georgia. Please feel free to like us or subscribe to us on YouTube. If you'd like to make an appointment with our practice, you can do so at www.beltlinehealth.com, or you can give us a call at 470-419-4380.